and welcome again to the Future of Healthcare webinar. This is a 5-week series of webinars where we're having an opportunity to meet with thought leaders, people who have innovated during a time of crisis. So as we move through the COVID-19 crisis, people have had to react. They've had to change their practice and they've had to move forward. We've had a great series so far. We've been in Hong Kong looking at big data. We've been in Malaysia looking at telehealth, been in Brazil as well and looking at the changes and innovation within that environment. And today we're moving on to a subject of radiology and innovation in radiology. What most people, well, hardly anyone will know about me and my CV. Before I became a nurse, I did 1 year of radiography training and nearly moved on to become a radiographer. So it is an area of real interest for me as well in this space. So this webinar, we're going to give an opportunity to hear from our speaker, do an introduction very shortly, but just to let you know about the Q&A process, we will ask people to select the Q&A tab. To type in your questions in there. We will be asking some of those questions of our speaker today. We will be sharing this as well after the event on a YouTube channel. We're hoping to present the first 2 sessions in the near future as they're ready. So moving to innovations in radiology, I want to introduce Dr. Bharat Agarwal, who really has been at the forefront of some of the innovations within India. Background in terms of radiology experience and currently Senior Director of Radiology Services at Max Health. Huge CV there, a lot of experience in different parts of introduction of radiology in different regions, interesting area of co-founder of the Amber Emergency Healthcare Technology Platform in the past as well. So I encourage you to go to our site and have a look at this CV and understand a little bit of the background. But I want to hand over to Dr. Bharat to really allow him to give us an opportunity in the next 10 minutes to hear about some of the innovations during COVID and some of his thoughts on the future post-COVID. Thank you.
Thank you, Tim, for the introduction, and to Elsevier for having me on board for this wonderful series, which I have been watching over the last couple of weeks myself. So moving on to what we're going to talk about today, the COVID pandemic has taught us as doctors and me as a radiologist things that were completely strange and completely unknown in our training. And some of the things that we've learned is listed here, which is there's a constant evolution of our standard operating procedures. And then words like scheduling, disinfection, rostering, personal protection, and contact tracing, isolation and quarantine are now omnipresent in our practices. And all this is because this bug that's going all around the world is something that we've really not got a grip on. So next slide, please. So the big things that we've learned, which reflect all these changes that we see in our day-to-day practice, are safety and flexibility. And I'll be basically focusing on these 2 things. And when I talk of safety, it's safety for our people, the patients, and the extended world around the patients and the healthcare workers, which is their families and friends. And when I talk of flexibility, it's the changing environment that countries have seen over the last many months of how the disease exists, grows, and spreads in their regions, which makes them have to innovate on the fly, be nimble, and constantly change from day to day and hour to hour to provide the 2 important things that any radiology service, or for that matter, healthcare service, has to do globally. And one is, the first is, of course, access to the service itself, which means you've got to be available to patients of COVID and patients who are not suffering from COVID. And within this whole chaotic environment, which is ever so changing, is to ensure that you provide a very timely service so that patients remain healthy, improve, and get rid of their diseases, whichever way they come through. Next slide, please. So what we have seen in the last 3 months since uh, India started getting its early cases of COVID was the environment in the hospitals changed dramatically, and there was a marked reduction in all the elective and routine work that we were doing, and we had to pivot pretty quickly to change the way we practiced. And these are some of the things that we actually did. We had to focus on improved safety for patients and personnel. We had to move our equipment closer to patients, whether inside the hospital that we did in our 14 hospitals that we operate, or the community has done in different parts of the country. And I think this entire situation has given a big boost to the integration of artificial intelligence into the routine workflow. Now, I personally have been working with India's top artificial intelligence companies who are now global in their presence, but there was always good to have as far as AI went. And in the last 6 weeks, we've actually seen the necessity to have um, the integration, utilization, and using this AI in ensuring that the two areas that I talked of, safety as well as the effectiveness, pretty much on track. And within this whole thing, I have personally seen an urgency and a need to improve the communication for the patient, for the referring clinician, between different people within the department to ensure that we keep everyone safe and treatment prompt. Next. So here's a quick example of an innovation we did. And I want to bring in and highlight one thing that we've seen globally happening, and that's democratization of knowledge. On a regular WhatsApp group, I actually saw an example of a shield such as this, which was being used in some hospital in Italy. And I actually passed it on to an engineering friend of mine whose factory was otherwise shut. And through his resources, from drawing board to actual delivery of these shields for our ultrasonologists, we were able to get them in our hospitals, in 10 different hospitals within the span of 3 weeks. And you can see that this is something which is now going to be commonplace for us. The entire protection for our patients, the hygiene, the disinfection, and of course, safety of our own personnel. Next. Like I spoke earlier, there has been a greater deployment of mobile DR systems in hospitals and isolation wards. And what's interesting is that there are some companies who are embedding artificial intelligence solutions within the point of care machines. We've done a project with GE last year for pneumothorax, and we're going to be seeing a lot more applications coming towards the patient so that instant diagnosis can be made. And while we are moving these systems closer to patients, making them more effective rather than delaying treatment, we are making it faster. And all this while we're also ensuring that there is protection for both the patients from each other by using these plastic shields on some of our CR systems where we could not get in our DR systems to the patient's personnel itself. Next. And this is an interesting concept that came in and is being effectively used by one of our AI partners, which is Cure.ai, in collaboration with the Mumbai Municipal Corporation, where they have their own AI software inside a van which has a mobile X-ray unit, which is being deployed in containment zones within Mumbai, ensuring that they're able to triage patients who actually need to get into hospitals and care facilities, because just a turnaround of RT-PCR can be delayed, and you don't want to keep highly infectious patients within the containment zone. Next, please. And this is something which we have also deployed very, very rapidly in our hospital. It took us 24 hours to get this solution deployed in our COVID-only hospital. Max Healthcare has, till date, dedicated one full facility of about 200 beds dedicated exclusively to COVID. And we deployed this solution, and on a daily basis, it helps us grade the disease, pick up some complications, and hasten our diagnosis and make it more effective. Next. And while we do that, in the COVID scenario, we are also in the process of deploying this and similar solutions to ensure that we actually triage and pick up patients with COVID in patients otherwise unsuspected of the disease, because there will be patients coming to hospitals for non-COVID related illnesses. And that's, if any of these patients have an asymptomatic or mildly symptomatic COVID, it is important for that patient and for the entire healthcare community to be aware of the fact that there is a patient with COVID who's otherwise unsuspected. So this is something which has really helped us get extremely proactive in highlighting whether a patient does have the suspicion of COVID, and therefore these patients can be moved towards a more isolated treatment area rather than be all over the hospital with so many points of contact. Next. And while we do this in X-ray, we are also in the process of deploying an AI solution through one of our partners to quantify and prognosticate patients with COVID. And again, use the same software to help us highlight what's happening in an otherwise unsuspected patient. Next, please. And while we do this, it's the communication which is really important in today's day and age. We do have an enterprise radiology information system in PACS, and we are able to communicate reasonably well, or thought we did reasonably well in terms of highlighting critical ailments. But what this scenario has done is it's helped us push proactively communication. And I've highlighted the part where a diagnosis is now going to be available through solutions such as the one Deep Tech offers, along with all the other partners, where we can now get instant notifications on our mobile phones where we can sort out those patients requiring urgent care. And while I talk specifically of COVID, next slide, please. All this is something which is going to be pervasive in the non-COVID environment within today's pandemic and the radiology of the future. And I think COVID has helped us accelerate adoption, allowed us to be more nimble, allowed us to experiment with an unknown enemy, and hopefully we will come out better. And within this whole ecosystem, the single change that we will all have to figure out is how to do it in a more economically viable manner, because what's happened with COVID is the global recession. And I pray to God that it does not become a depression. But within the constraints of the shrinking economies globally, we will have to make healthcare more efficient. I currently see that happening, and I am optimistic that all the changes that we will see, some of which I've listed in this slide, will be real. Patients will be safer. There will be more things happening outside the hospitals rather than within the hospitals. And therefore, there will be a greater efficiency and reduction in cost. Patients who will need treatment will come to hospital and will be treated more effectively. I'm happy to wrap up now. Tim had asked me to speak for 10 minutes or less. I hope I've stuck to that.
Yep, you have hit the exact time. So thank you very much for that. And we can start to ask some questions of you now. Just a reminder, please put your questions into the question box Q&A at the bottom of the screen there, and we can get to those. India at the moment is on the rise in terms of the numbers of patients who are diagnosed with COVID-19 at the moment. Can you give us a sense in terms of Max Health of the pressures that perhaps you've been experiencing in your departments, but also generally across the hospital? We know that, of course, electives have reduced, but has there been a wave of pressure?
So Tim, it has been extremely chaotic from early March, just before India went into lockdown. And I remember people asking me on a personal level that, what do you think about this? And I would tell them, wait for 2 weeks. and we will figure that out. Those 2 weeks have become 3 months, and I discarded this term almost a month and a half ago, just because of the fact that things have changed so dramatically and rapidly, and obviously it's affected our organization significantly. Well, early on in the disease, the first thing that happened was the fact that the elective patients stopped coming to hospitals, partly because of lockdown, partly because of their own fears. And the hospital had to turn around very, very quickly to provide teleconsult services for patients at home. And that too was a great innovation, where our IT team actually converted 20% of the pre-COVID consultations on e-consult pretty quickly. And while initially the hospitals were gearing up to take in the load of patients, because of the lockdown, that didn't really happen. And that meant more preparedness, more uncertainty, obviously the regular work going down. And then as the lockdown has slowly opened, we've seen this deluge of patients. We did a very, the management of Max did a very sensible thing where we converted one full hospital into a COVID facility. There was a requirement by the government to allocate a certain percentage of beds. And instead of doing it in every building, we actually created a dedicated COVID hospital that helped us put the resources in a single place and optimize simple things like PPE and face shields. Radiology became more efficient because not only did we have point of care portable machines, we had a full department within a COVID facility, which meant that we could offer a comprehensive service to a COVID patient who was very sick. What's happened off late is that because of the acceleration over the last 2 weeks, there is a need for providing greater number of beds beyond what we could offer then. And obviously the hospital is in the process of doing that. And for a brief period, all the patients who were waiting for the first 2 months came into the hospital for getting their other treatment done. And that's when we saw the chaos of coming into contact with otherwise unsuspected patients. And that's where contact tracing became big.
And in terms of we saw yesterday when talking with Dr. Rebello in terms of the waves of expectation for post-COVID, we've got the third wave, which could be the people with long-term conditions, those who have not had the early diagnosis. Presumably in a radiology suite, you would be seeing a vast number of patients who potentially have early stage cancer or have disease that needs treatment. Has there been perhaps some delay in identifying those patients, or how have you managed that?
Well, the good thing that happened was that the hospitals have opened up for this brief period, and patients have come in. Our screening program has taken a huge hit, and we're still not seeing those early cancers yet, just because those patients are not coming into hospitals. India is lagging behind a major part of the world significantly. And I think we will be seeing that in the future, where we will start seeing inoperable or more advanced cases of cancer, while we should have picked them up during this period.
Yeah. And I mean, turning to your AI initiatives, these are quite exciting, and obviously the volume of images that you'll be capturing during this phase, both mobile and within the hospitals as well. Can you just explain a little bit about how do you go about getting funding for some of those projects? Because they are often on the cutting edge. It is perhaps not one of your normal budget requirements. Where would you drive the funding for that?
Well, that's a tricky one, Tim. The good thing is that the partners whom we have been interacting with are extremely keen to work with the 100-odd radiologists who are part of my team. And we actually subsidize the cost by providing our services to some degree and contributing more towards the evolution of the product. Max Healthcare does have a very large research wing, and we are able to get some degree of grants and aids specifically for research, and that's something we plan to optimize. In fact, during this pandemic, I think we're running tens of papers across different specialties, including that within radiology. All that is currently self-funded at this point.
And in terms of the AI technology, I mean, one of the areas I was quite interested in is whether in routine radiology, when passed through the AI technologies, are you starting to identify patients who were asymptomatic with COVID-19, who are showing up with lung changes or through CT? What are you seeing there?
Yes, we are. I mentioned that earlier, that it's the non-COVID indication patients that we are picking up using both AI and radiology intelligence or radiologist intelligence, a combination of both. It is there, and we do see this every day. And obviously, it leads to a whole chain of events, which is completely driven around not just making that diagnosis through AI or a radiologist, but then going back and ensuring that everything or every place of contact for that patient remains safe for everybody else as well. So we're seeing a reasonable rise in that segment of patients as well.
Excellent. And then patient safety, but radiology and radiographer safety is key, as you mentioned. You've done some innovative ways, very simple ways of putting that protection between the particular radiographer and the patient. In many respects, nurses have been the ones on the front line who have actually been impacted quite badly by COVID-19, particularly those who are not in intensive care. We've seen this in community care, in radiographers, and have the people on the front line also been hit by this illness themselves?
Tim, I lost you for just the last part of your question when you talked about the nurses.
Just wondering whether the radiographers and other people on the front line who are going out to see patients, have they also been hit by the illness themselves? Have you lost staff in this process?
Yes, we have. Yes, we have. So the experience is quite simple. If you have a dedicated COVID facility, the incidence of staff getting affected is much, much lower than an open facility. And we have seen the last 3 weeks, especially, where radiographers, even our radiologists in India, ultrasounds are done by radiologists themselves and not technologists. And some of the nursing staff within a department has got affected because of an inadvertent contact with a COVID patient in the hospital. And it's a huge exercise the moment a patient comes positive, where you have to go through contact tracing. And like I said, it's a combination of balancing the work that's coming in and ensuring that you have a supply of adequate staff to deal with situations if people start falling ill.
Yeah. And it's obviously it's very upsetting for other members of staff involved in that as well. AI is a very natural place in radiology. We often think, if you're thinking of AI, radiology follows. I think I challenged you on this question previously in one of our chats, whether AI sees the end of the radiologist expertise. You know, what is your position on that?
My answer remains the same. The answer is no. I think the radiologists are here to stay. And like a lot of other specialties or areas of life beyond healthcare, where AI, computers, automation have changed the lives of people who were previously doing that work by reducing their relevance in what was today's job description. I think the radiologists will evolve into being more participatory in decision making, which even today radiologists are. And a lot of the grind work will be done by AI for radiologists, making them more efficient, making them more accurate, more relevant, and I think most importantly, more proactive in giving a timely and a better and a more correct diagnosis.
Yeah. And I think of your role as a senior leader within radiology. Do you you look at education of medical students and junior doctors, junior radiologists? How do you think we need to adapt our training to understand the results of AI diagnostic image recognition and things?
Well, the first thing is to have a greater penetration of AI across the spectrum of both education and non-education healthcare facilities. And that's happening. Like I said earlier, COVID is enabling that to a great degree, even in private diagnostic centers, which are not hospital-based, because they too are responsible for picking up disease for their own safety and that of the patients. The good thing about radiology residents and young radiologists is that traditionally radiology has been extremely technology driven. So adoption of AI is a natural process for an average radiology resident. I think there is more and more incorporation of AI in curricula globally. And in fact, all the international conferences have seen far greater presence of AI companies. And what's an interesting twist to that is that the radiologist is today more relevant